So we come to the last leg. I'll just go through two cases of TAVR, which I've done recently. So we are doing a lot of TAVR cases, and this month I have done almost 8 TAVRs already, near the 20th of December. Still 10 days left, and somehow the TAVR numbers have gone up, and it's just going to grow everywhere. So I'll show two cases where the gradient was more than 100. The mean PG was more than 100. The real high gravity aortic stenosis where patients were very sick and they required the procedure at any cost. So I'm showing those two cases. And before, I think Tejveer is around. Tejveer, I'm sorry, we'll take it in next. It's getting prolonged, right? I don't know Tejveer is here or not, but I think message has gone to him. So this is optimizing outcomes in tough cases, in complex anatomies. This is the first case, 67-year-old female. Now look, patient had undergone aortic valve replacement with a surgical bioprosthetic valve with a 19 mm peri-mount valve. So many years back, this lady had undergone this AVR, and the valve size is only 19. And look at the echo gradients, more than 100, a severe aortic stenosis, and very symptomatic lady. So in this case, there are two issues. One, there is a small annulus and gradients were very, very high, patient highly symptomatic. So this is the CT analysis. Look at that now in 19 millimeter valve, which has already been there at the aortic position. So we do expect the annulus of only 17. So 1 millimeter on both sides, all through the circumference is actually deducted, and the true size of the valve now is 17.5. So now sinus of valsalvas were not very spacious, but okay. And coronary heights were again a little bit smaller. Right. So this is the situation. This is the hemodynamics. And look at this. Now, in such situations, we need to take care of few points. One, obviously, once we are doing a valve in valve, we have to have a VTC. The valve to coronary distance should always be checked, and that we always check. As a routine in such cases, there is a chance of obstruction happening. So this is the VTC. Look at this. Now VTC was spacious. So this is important. This is valve in valve. We are going to place a new valve here. RCA 7.2 and LCA 7.6. So if it is more than 4, we are comfortable. So perimount is fracturable valve. We do expect in a smaller anatomy, once we place a valve, that gradients would be high. We may need to fracture the valve, and this is how we plan that. So this is the height, and we should actually know the height of the leaflets and height of the frame. So 13 is the height of perimount, and we are talking of 19 valve, 18 is the inner diameter. But since it is gone from both sides, actually the space left to us is 17 only. So this is the angle, and this is the femorals and iliacs. They were okay. So procedural considerations are very important. It's a smaller anatomy. We wanted to have a valve which is a supraannular, gives a better orifice area. So Evolute FX from Medtronic is a beautiful valve which gives us better areas in such situations. In smaller anatomies, I think this is the way to go. And we do all the procedures in conscious sedation, and then at the end we do expect that our gradient should be as low as possible. This is a puncture site. We always do as a femoral angiogram, and then this is a aortogram. We check everything in the aortogram as a step number 1. So, and this is the Evolute FX. So we go very slow. So now we remove the parallax of the previous valve, and once the parallax is removed, we start deploying this valve very slowly. We can pace so as to minimize the cardiac output, and then deploy it very slowly. Once we are comfortable, we totally deliver this valve, and this is how it looked. Very good depth, so we can always control the depth in such situation. If we remove the parallax, it is equivalent to the cuspal overlap view. So and then valve fracture was required. We were expecting it's a smaller anatomy. After we deployed, see, initial mean PG was more than 100. So after deploying the valve, the PG mean PG was still 30. So obviously, in a smaller anatomy, this is going to happen. So this is a fracturing of the valve, and it is done by Atlas balloon. So it is done. It should be done, and the balloon sizing should be taken one additional size to the previous valve. The previous valve was 19, and so Atlas balloon has to be 20, and then you keep inflating. It's a slow and prolonged process. So TPI, pacing the heart, and slowly you go up, go up, go up, and we have to stretch it hard. Now the beauty of this balloon, Atlas balloon, is it doesn't grow in size. So it will stay at 20, but it will keep taking the pressures. So that is where the fracturing happens. And after the fracturing was done, it was all good, and the gradients actually reduced from 30 to 2 millimeter mercury, and no PVL. Patient was discharged in next 2 days, doing very well. So this is one case. This is a second case, another atypical case. We know that young patients are not good for TAVI, but this was a very unusual case. A 42-year-old person, 160 kg. His weight was 160 kg. He was not even coming on the cath lab table. So, diabetic, hypertensive, and we actually admitted this patient for AVR, surgical AVR, but then anesthetist and surgeons totally refused. So, and patient was highly symptomatic. Again, the gradients were more than 100 millimeter mercury. I'm talking of mean gradients. So, bicuspid anatomy, very high gradients. This is the CT analysis. As 27.6 is the annulus diameter, area of 579. Very spacious sinus of Valsalva's, no issues, coronary osteas were fine. This is the pictures, and now there was some issue with the sizing. Now I think there's not within the realm of this discussion, but once there is a bicuspid, we need to figure out whether this is a funnel or an inverted funnel. If it is an inverted funnel, we should take the sizing of the valve as per the intercommissural distance at 4 millimeter above the aortic annulus. So in this, it was different. If we talk of the aortic annulus, the size coming was 34 millimeter. But because it was an inverted funnel, it was not like this, it was like this. So then 4 millimeter ICD, that gives you a better sizing of your valve. So we took 29. So I'm saying this. So now this is 26.9 ICD at a 4 millimeter above the aortic annulus. So based on that, we took 29 rather than 34. So this is important at times. So again, I evaluate FX 29, and it's a better controllable valve, and patient was very young. This is the aortogram. This is the evolute valve, dilated, and a cuspal overlap view, and slowly deploying. We have to recapture and deploy 3-4 times because we were expecting that. That's what I'm trying to say. If we take even 34, it will further move more. The LVOT was bigger. The annulus was bigger than the intercommissural distance at 4 millimeter. So good, we took 29, and we could actually stabilize the valve in 2 or 3 positionings. Now look at this, it was still deep. It is still very deep. We recaptured, and this is a better depth. So then we deployed it here. So this is a deep, and this is a better depth. Recapture and deployed, and this, and we deployed at this position. Look, so this is a better depth, and then finally we deployed it here, and result was all okay. So this is a final release. So basic idea is planning TAVI is very important. It is a meticulous planning we should do with all the CT sizing analysis, and then plan a case. Execution is also very important. So now, you know, uh, I do personally around 8 to 10 towers a month now. Our timing, our cohesion with between the team has really efficient, and we do finish a case in 45 minutes to 1 hour now. So mostly, but still, I would say the pacemaker rate after TAVR is still 10-12%, not less. It depends on a lot of stuff. But as figures point that it is 5%, 6%, no, it is still in double digits. So, but results have becoming more and more acceptable and gratifying with TAVR. So these were two interesting cases. I have many more, but we'll keep discussing in various sessions. So thank you from my side, and thanks for being there on Sunday. It was a very good session, and I wish everybody a Merry Christmas and Happy New Year. We'll meet again in January next year with another session of Acardmy, and I wish everybody a very happy Christmas and a very happy New Year. Now, before concluding, I think the final is that we need to decide amongst the cases, and I tell you, it was actually very difficult today. It's been a really interesting cases. What Amjad presented was a very nice procedure, a new innovative stuff to wire a very awkward looking side branch ostium where the wire doesn't go very easily. So that was very good. Then Karan's case was very good, where he actually had a horrible scenario with dissection entering into the circ, and circ totally got occluded. Even SP's case was very good, and then the Leap's case was also very good. But I think somewhere we have to pick and choose. But still, my instinct says that it should be clubbed with Amjad and Karan today. So they were absolutely brilliant with their cases. So well done, Dr. Amjad, and well done, Dr. Karan. So
Thank you so much,
you
sir. Thank you.
you
Thank you
took
so much, sir.
first spot in today's session, and everybody's cases were equal, just that everybody's turn comes at some point. So, all the very best and congratulations. Sagar will be the one who will be sending you your compliment as winners. And we look forward. Please share your pictures. Let's keep this group very bright, and let's keep discussing. See, everybody's learning. So Amjad's case was like a good learning. And then to keep our reflexes on as an interventional cardiologist, we have to keep discussing the newer things. Thank
Thank
you.
you. Thank you.
Thank you all. And
Thank you,
all
sir.
congratulations to the winners and to everybody. And let's meet again in January. And Happy New Year to all of you again.
Happy New Year, sir.
Thank you.
Happy New Year,
Happy
sir.
New Year, sir.
Happy New Year, sir.